Next slide.
Good morning, everyone. Today I'll be discussing about systemic pathology topic, that is hepatobiliary system. So we have to know the topics which I'm going to discuss. First will be the introduction related to the anatomy, histology, and the functions. Then infectious pathology, that is hepatitis, some of the pyogenic infections, and some drugs and toxins like alcoholic liver disease, jaundice, then cirrhosis and portal hypertension. So some of the metabolic liver diseases are hemochromatosis, Wilson's disease, then autoimmune diseases, autoimmune hepatitis, primary biliary cirrhosis, and tumor and tumor-like lesions. So to start up, let's revise the gross as well as the microscopic features of liver. So macrostructure of the liver is, so the liver is the largest visceral organ in the body and is primarily in the right hypochondrium and epigastric region, extending into the left hypochondrium. It has got two lobes, that is the right lobe of the liver, which is the largest, and the left lobe, which is the smallest. You have the porta hepatis, which serves as the point of entry into the liver for the hepatic arteries and the portal vein, and the exit point for the hepatic ducts. So you have the hepatic artery being the blood supply and the venous drainage. So from the liver you have the sinusides, which is united with the hepatic vein that drains into the inferior vena cava vein. So you have the ligaments. Anteriorly is covered by the fold of peritoneum called as the falciform ligament. Inferiorly by the fissure for the ligamentum teres. Posteriorly by the fissure for the ligamentum venosum. So microstructure of the liver. So you have the lobule model as well as the acinar model. The lobule model is hexagon lobules, which is oriented around the terminal tributaries of the hepatic vein, which is called as terminal hepatic veins, with the portal tracts at the periphery of the lobule. The hepatocytes in the vicinity of the terminal hepatic vein are called as centrilobular. Those near the portal tract are called as the periportal. So then you have the acinar model. Hello, sorry for the inconvenience. So let's start up again with the microstructure of the liver, which has got the model and HNR model. We have the lobule model is hexagonal lobules oriented around the terminal tributaries of the hepatic vein with the portal tracts at the periphery of the lobule. The hepatocytes in the vicinity of terminal hepatic vein are called as centrilobular, and those near the portal tracts are called as periportal. So you have the acinar model, that is the hepatocytes near the terminal hepatic veins, which are the distal epiphyses of roughly triangular acini, whose bases are formed by the penetrating septal venule from the portal vein extending out from the portal tracts. So now coming to the different zones of the liver. Before that, let's learn about the histology. So in the histology, you can see the photomicrograph showing the hepatic parenchyma, which is composed of hexagonal or pyramidal classical lobules, and each lobule has the central tributary to the hepatic vein, and at the periphery are 4 to 5 portal tracts, which is composed. They're also called as triads, which are composed of bile duct, portal vein, and hepatic artery. Cards of the hepatocytes and the blood-containing sinusoids radiate from the central vein to the peripheral portal triads, and the blood supply to the parenchyma flows from the portal triads to the central veins. So here you can see in the picture, the central vein you have the lobule, hexagonal lobule, parenchyma, with the cords of hepatocytes, and you have the central vein here, which is in the cords of hepatocytes, you have the sinusoids. And this is called as the portal triad, which is having the hepatic artery, veins, and the bile duct. So next, coming to the zones and knowing the importance of the zones. Zone 1, or the periportal peripheral area, is closest to the arterial and portal blood supply, and hence bears the brunt of all the forms of toxic injury. So Zone 3, or the centrilobular area, surrounds the central vein and is most remote from the blood supply, and thus suffers from the effects of hypoxic injury. So in between the Zone 1 and the Zone 3, you have got the Zone 2, which is also called as the intermediate or the mid-zonal area. Coming to the functions of the liver, so it manufactures and the excretion of the bile, manufacture of several major plasma proteins like albumin, fibrinogen, and prothrombin. It helps in the metabolism of proteins, carbohydrates, and lipids, and helps in the storage of vitamins like A, D, and vitamin B12 and iron. The main important function is the detoxification of toxic substances like alcohol and drugs. Now, coming to the patterns of hepatic injury. So, before going to the individual pathology, we have to know the patterns of hepatic injury. So, you have here degeneration and intracellular accumulation. So, in that, you have ballooning degeneration or steatosis or fatty change. I think you all have learned in the first chapter, that is cell injury. So, necrosis, where you have this focal necrosis, zonal or bridging or submassive or massive, is depending upon the zones and the central vein and portal triads. So apoptosis is another form of irreversible injury, where you in the liver you have it as a councilman body. Then you have regeneration and fibrosis. So coming to the ballooning degeneration, you can see the micro photographs here. It's also called as feathery degeneration. So you have swelling of the hepatocytes. See the higher magnification. See this is a portal triad here. You have completely here swelling of the hepatocytes with increase and pale cytoplasm. So this is a pale cytoplasm is centrally placed here. In higher magnification, you have a granular cytoplasm with centrally placed nucleus. So these, so here you have lytic necrosis. So this necrosis is completely, the tracts are surrounded by the neutrophils and the necrotic debris and the inflammatory cells. This fatigue change. So fatigue change is nothing but the deposition of the fatty acids or triglycerides in the hepatocytes. So you have here, it's been divided as microvesicular steatosis and macrovesicular steatosis. So in microvesicular steatosis, you have this multiple tiny cytoplasmic fat droplets, where you can see here, these are all nothing but the intracytoplasmic fat droplets that do not displace the nucleus. So it's associated with alcoholic liver diseases, acute fatty liver or pregnancy, outdated use of tetracyclines, valproic acid, and sometimes in treatment of HIV there is a nucleosides. So these are the main reasons for microvesicular steatosis. Then you have macrovesicular steatosis. Here is the deposition of the intracytoplasmic fat droplets, but the nucleus. So you have large droplets here in the hepatocytes, where you have the displacement of the nucleus, peripheral push nucleus here. Here you can see peripheral push nucleus. So this is associated with alcoholic liver disease, obesity, diabetes, non-alcoholic steatohepatitis, some drug reactions, and cystic fibrosis. So you have necrosis, the next degeneration. So necrosis, what do you understand by necrosis is? It's another form of irreversible injury where you have cell death is there and degranulation of completely intracytoplasmic granules. So here you can see the photomicrograph showing completely hepatic necrosis here. These are the normal hepatocytes. This here focal areas where you can see the amorphous eosinophilic deposits of necrotic material. So you have the completely surrounded by the necrotic debris, the inflammatory and the inflammatory cells. This is a massive necrosis here, and this is completely the degeneration surrounded by the inflammatory cells. So based on the location is classified as portal central, central pattern. So this is also called as the bridging necrosis. Next you have the centrilobular necrosis. Centrilobular necrosis in this picture you can see completely here. This is a focal necrosis around the central vein. So here necrotic hepatocytes around central vein, usually due to ischemia, drugs or toxins. Common finding at the autopsy because it is associated with circulatory failure or shock. Next, you have the focal necrotic lesion with neutrophils and necrotic debris. This is called as peaceful necrosis, which affects the hepatocytes. Irregular necrosis it is, along with the neutrophilic infiltrate, especially the polymorphs, at the limiting plate. And this is a massive necrosis. It's called a submassive necrosis. It's prominent involving the centrilobular zones or the entire lobules in most of the liver associated with hepatic failure. So next degeneration is the Mallory hyaline, also called as Mallory bodies or alcoholic hyaline. So in this you can see completely the hepatocytes with irregular rope-like, sharply defined intracytoplasmic eosinophilic deposits of cytokeratin, often in the degeneration, ballooning cells surrounded by the neutrophils. It's associated with alcoholic and non-alcoholic steatosis, various cholestatic conditions like Wilson's disease. Next, you have the acidophilic bodies. So this arrow shows you the acidophilic body here, and in the hepatocyte you have the that is the acidophil body here, which is defined as like is Shankar eosinophilic round body with variable nucleus. It's called as Councilman body or apoprotic cell. So this signifies non-specific hepatocellular injury. And there's no inflammation surrounding this. So you all know that in irreversible injury One of the form is there is apoptosis, whereas shrinkage of the nucleus without any inflammation. So the difference between necrosis and apoptosis is going to be necrosis is going to be cell death with lots of inflammatory cells, and apoptosis is going to be shrunken cells without any inflammatory cells. So next, coming to the topic like infectious, that is hepatitis. So let's discuss what are the causes of hepatitis. Again, sorry for the inconvenience, lot of network issues. So if you all have missed some class like related to the necrosis, let me start again. This necrotic cells, the bridging necrosis, where you have this massive necrosis here, completely entire lobules. So they're divided as portal central, central pattern, that is called as bridging necrosis. So centrilobular necrosis, where you have this is focal necrosis here with hepatocytes surrounding the central vein. So it's related to ischemia, drugs or toxin. Common finding at autopsy because it is associated with circulatory failure or shock. Then this is another focal necrosis where individual hepatocytes is necrosed along with the inflammatory cells as the neutrophils. Here you have completely the irregular necrosis, which is called as piecemeal necrosis, which affects the hepatocytes at the limiting plate. Then you have submassive necrosis. It's prominent necrosis involving the centrilobular zones. So these are the centrilobular zones here. Zones of or entire lobe also could be involved, especially in case of hepatic failure. So this is a Mallory hyaline or Mallory bodies or acidophilic hyaline. So this is a hepatocyte here, normally centrally placed nucleus, and this is a rope-like sharply defined intracytoplasmic eosinophilic deposits, which is made up of cytokeratins seen in ballooning cells surrounded by the neutrophils. So this is nothing but the apoptotic body. So it's associated with alcoholic and non-alcoholic steatosis, various cholestatic conditions like Wilson's disease. So this is another inclusion. It's called as acidophil body. So type of focal necrosis in which you have dead hepatocyte is identified as shrunken eosinophilic round body with variable nucleus, which is not accompanied by inflammation. So this is called as Councilman body or apoptotic cell. This is a higher magnification showing the Councilman body. So this signifies the non-specific hepatocellular injury. So coming to the hepatitis as such, so let's learn what exactly you mean by hepatitis and what are the causes for hepatitis. So hepatitis is a systemic disease with primary inflammation of the liver, and the condition can be self-limiting, healing on its own, or can progress to scarring of the liver. So etiology is you have got hepatotropic viruses and non-hepatotropic infectious agents. Hepatotropic viruses mainly the hepatitis A, B, C, D, E as well as G. Other viruses that can also cause liver inflammation is herpes simplex, cytomegalovirus, Epstein-Barr virus or yellow fever virus. You have non-hepatotropic infectious agents like toxoplasma, leptospira, tube fever. Other things, drugs and toxins you have, alcohol, then toxins could be amanita toxin in mushrooms, carbon tetrachloride. Drugs could be related to paracetamol, methyl dopa, then nitrofurantoin, INH, and ketoconazole, some of the fungal drugs. Autoimmune conditions, and then you have metabolic diseases like Wilson's disease and alpha-1 trypsin deficiency. Clinical terms you have to know is what do you mean understand by acute viral hepatitis, which means the symptoms last less than 6 months. Chronic hepatitis is inflammation which lasts for more than at least minimum of 6 months and more than 6 months. Pulmonary hepatitis is severe impairment of hepatic functions or severe necrosis of hepatocytes in the absence of any pre-existing liver disease. So this historical perspective which shows how it can be infected or transmission. So infectious is hepatitis A, viral hepatitis that is hepatitis C, which is parentally transmitted, and serum hepatitis is B and D, as well as here you have parental transmission is G. Enterically transmitted is going to be hepatitis E. So coming to the individual viruses, so before studying, you have to know the structure of the viruses. Any terms used instead of the like hepatitis A virus is called as hepatinovirus. Then coming to the clinical pathology, pathogenesis, as well as the diagnosis and management aspects. So this hepatitis A virus was formerly known as infectious hepatitis or epidemic jaundice, which causes an acute infectious disease. And the disease is heralded by non-specific symptoms such as fever, chills, headache, fatigue, generalized weakness and pains, followed by anorexia, nausea, vomiting, and jaundice. Coming to the structure here, it was first demonstrated in the feces by Feinstein in 1970. It is 27 nanometers non-enveloped RNA virus, which is also called picornavirus. So it contains 4 capsids or the polypeptides. So epidemiological determinants is it's an enterovirus that's picornaviridae family. It multiplies only in the hepatocyte. The virus is very resistant to heat and chemicals. It is inactivated by ultraviolet rays and by boiling for 5 minutes or autoclaving. So when you're looking at the pathology, it enters through the mouth, that is ingestion. So multiplies in the oropharynx and the intestinal epithelial cells. Then transmission to the lymphatics of the bloodstream, enters the liver, and further replication and the disease progresses. So mode of transmission is spread by fecal route and arises from the ingestion of contaminated food or water. Overcrowding and poor sanitation facilitate the spread. Both sexes are equally susceptible, and the disease is commonly seen in children and young adults. It replicates in the liver, excreted in the bile, and is then excreted in feces of infected persons for about 2 weeks before the onset of the clinical illness and for up to 7 days. So the disease is maximally infectious just before the onset of jaundice. So coming to the incubation period is 2 to 6 weeks, and there is no carrier state. So you can make out here 2 to 6 weeks what happens, 15 to 45 days that is the incubation period. Then acute diseases, there will be increase in the transaminase, elevated transaminases or you call liver enzymes as well as jaundice. And you have development of the antibodies here, that is IgM antibodies in the early exposure and IgG antibodies in the later exposure. So coming to the investigations, you have elevated enzyme, liver enzymes, that is aspartate aminase and alanine transaminases. You have AST level reaches a maximum of 1 to 2 days after the appearance of jaundice and may rise above 500 international units, and the amylotransferases may remain elevated for some weeks and occasionally for up to 6 months. So hematological tests is there is leukopenia as well as lymphocytosis. The ESR is increased, and you have molecular diagnostics is RT-PCR. So course and prognosis of this disease is, the prognosis is excellent with most patients having complete recovery. The mortality is in young adults is 0.1%, but it increases with age, and death is occasionally due to fulminant hepatic necrosis. This never progresses to chronic liver disease, and there is no specific treatment, and rest and dietary measures are unhelpful. So prevention is general measures to improve sanitation, that is proper disposal of sewage, safe drinking water, food and food hygiene. Vaccination could be passive immunization. So passive is going to be human immunoglobulins. given before the exposure to virus or early during the incubation period, which will prevent or attenuate the clinical illness. So active immunization is several inactivated or live attenuative vaccines against hepatitis A have been developed. So coming to the next important hepatitis virus is the B virus. It was formerly known as serum hepatitis. It's an acute systemic infection with major pathology in the liver. The acute illness causes liver inflammation, vomiting, jaundice, and rarely death. So epidemiology is the hepatitis B virus is present worldwide with an estimated 300 million carriers. It is an endemic throughout the world, especially in the tropical and the developing countries. So let us learn the structure. The structure is important for us to know the antigens as well as the antibodies for the serological for detection of the serological marker, which helps us in the diagnosis. So this virion is called as Dane particle, which is 42 nanometers double shell DNA virus. It comprises an inner core. It's an inner core or nuclear capsid, which is surrounded by the outer envelope, that is the surface antigens. It's called a HbS-AG antigen. So it replicates in the liver, and this surface coat is produced in excess by the infected hepatocytes and can exit in the serum and the body fluid. Coming to proteins here, which helps us in the diagnosis, you have the core proteins. There is a core particle which has got kinase activity, which plays a very important role in replication. Pre-core or HBE antigens is a good marker for active replication. Surface antigens, these are envelope proteins of hepatitis B, that is basis of current vaccine. Then pre-S2 and S1, they are binding proteins and entry into the hepatocytes. Then you have polymerase, which determines the viral replication, and X protein, which tells us the transcriptional and transactivator activity. Coming to the mode of transmission, it's a parental, that is IV drug abusers, health workers are at increased risk, tattooists or acupuncturists, then sex workers and homosexuals are particularly at risk. So perinatal transmission is called as vertical transmission, that is from mother to child during parturition. Soon after birth, its usual means of transmission worldwide. So incubation period is going to be 45 to 180 days, usually 60 to 90 days. And clinical features is jaundice, tiredness, anorexia, vague abdominal discomfort, nausea, vomiting, and arthralgias. This is the clinical course of the completely about the HPV infection in adults. So you have your acute course here, about 25%, about more than 25%, or more than 65% go for subclinical infection and recovery. About 25% of them progress to acute hepatitis. So less than 1% you have incidental death findings, and 90% they recover. So here you have about 1 to 10% go for chronic hepatitis, 60 to 80% of them are non-progressive, and 20 to 40% they are progressive. So they develop into cirrhosis and then hepatocellular carcinomas. These are the outcomes of the hepatitis B infection. So this photograph shows you completely the different forms of microscopic degenerations or the injury. So you have the A is the interface hepatitis. You have the central vein, the portal triad, this proliferation of the ductules, bile ducts. You have the inflammatory cells around the central veins, that's the neutrophils. Then you have the D, it shows ballooned hepatocytes and splotchy necrosis. The splotchy necrosis where you have the constituent bodies, and this is completely the inflammatory cells. So you have the ground glass appearance of the hepatocytes. We show abundant granular cytoplasm with peripheral cytoplasmic clearing and centrally placed nuclei. This is a clearing here and centrally placed nuclei. So then is the bridging hepatic necrosis. These are the microscopic features which is seen in case of acute hepatitis. So following an acute infection, which may be subclinical, and approximately 1 to 10% of the patient will not clear the virus, and most will become carriers of HbS-AG. So asymptomatic carriers are usually discovered incidentally on blood tests, like when they are screened before blood transfusion. Most of them remain as HbS-AG positive, but do not develop any active liver disease. There is an annual spontaneous clearance rate of HbS-AG of less than 1 to 2%, and these patients need to be followed up. So diagnosis is serological markers where you have elevated enzymes and total bilirubin is elevated. Histologically, you can demonstrate by immunoperoxidase stain. Then HBV viral DNA, most accurate marker of viral DNA and detected by PCR. So liver biopsy is to determine the grade of inflammation as well as stage of fibrosis in case of chronic active hepatitis. So here you have a graph which describes the antigens as well as the antibodies. You have the incubation period of 30 to 180 days. And in acute disease, you have the elevation of the enzymes as well as jaundice. So what are the antigens being raised? At the 6 weeks of exposure, you have HBsAg. 3 to 6 weeks, you have HBeAg. HBV DNA, you have early exposure. So you have the antibodies like IgM at the level of 4 weeks, then anti-HBe at 6 weeks, IgG anti-HBC is 12 weeks, and anti-HBs is 20 weeks. What is the significance of these viral markers? The antigens, HBsAg first marker to appear in the blood after infection. So this you have to know because you have to know what test has to be done, whether you have to detect the antigens or the antibodies after the exposure. So HBeAg implies viral replication and infectivity. So persistence of the HBeAg in serum beyond 3 months indicate continued infectious state. These antibodies anti-HBs, immunity to HPV, previous exposure or vaccination, anti-HB seroconversion, anti-HBC means replication, IgM is raised in case of acute hepatitis B, that is in acute conditions. In IgG is after the exposure to hepatitis infection. So prevention is vaccination. You have very highly effective recombinant vaccines are there. There are immunoglobulins, they are called as, which is given to patients 48 hours of the incident, or neonates whose mothers are HbsAg and HbAg positives. Other measures is screening of blood donors, blood and body fluid precautions has to be taken. National immunization schedule vaccine, that is at birth or as soon as possible within 24 hours. And then in case of adults, you have the antiviral agents. That is in case of progressive disease. There is interferons, lamivudine, then adafovir and tenofovir are the most commonly used drugs. Coming to the hepatitis C infection, it's the most acute infections. They are asymptomatic with about 10% of the patients having a mild flu-like illness with jaundice and a rise in serum aminotransferases. It is estimated that 150 to 200 million people of the world's populations are living with this infection. This infection is prevalent in India too, with an estimated 12.5 million. 50 to 80% of the patients progress to chronic hepatitis. Coming to structure, it's about 50 to 60 nanometers virus with a linear single-stranded RNA genome enclosed within a core and surrounded by an envelope carrying glycoproteins. It's a member of the family called as Flaviviridae. In addition to the replication in the liver, the virus can multiply in the lymphocytes too. So what is the incubation period? It is around 40 to 120 days. Mode of transmission is intravenous drug use, healthcare exposure, that is blood transfusion, transfusion of blood products, organ transplant without any HCV screening, which carries a significant risk of infection, hemodialysis, then accidental injuries with needles and sharps, sexual or household exposure to anti-HCV positive contact, multiple sex partners, vertical transmission, that is from an infected mother to her child. Clinical features is patients with chronic hepatitis C infections are asymptomatic. The disease being discovered only following a routine biochemical test with mild elevations in aminotransferases, that is ALT, is noticed in 50% of the cases. The elevation in ALT may be minimal, and some patients have persistently normal ALT, that is less than 25%. The disease being detected by checking the HCV antibodies, example in case of blood donors. So those with severe inflammation, a few patients develop cirrhosis. Diagnosis is ELISA. HCV RNA should be assessed using quantitative PCR. Liver biopsy is indicated if active treatment is given. So that is being considered. So in most cases, the features of chronic hepatitis are present. Lymphoid follicles are often present in the portal tracts and fatty change is frequently seen. In the treatment aspect, it's appropriate for patients you have to know to which patients you have to give medication. So the patients with chronic hepatitis on liver histology who have HBV RNA in the serum and who have raised serum aminotransferases for more than 6 months. So patients with persistently normal aminotransferases are also treated if they have abnormal histology. So patients with decompensated cirrhosis should be considered for transplantation. So next is, after this you are going to give the antiviral agents, if still progressive. So what's the aim of this treatment is to eliminate the HCV RNA from the serum in order to stop the progression of active liver disease to prevent the development of HCC, that is hepatocellular carcinoma. So how do you prevent this HCV? Screening of blood, organ or tissue donors, blood and body fluid precautions has to be taken, and vaccination. So next, coming to the structure of the hepatitis D. So this is called as HDV or Delta virus. It is an incomplete RNA particle enclosed in a shell of HBsAg. So it is unable to replicate on its own, but is activated by the presence of HBV. The incubation period is 2 to 12 weeks. Mode of transmission is, it's particularly seen in intravenous drug abusers. This infection can occur either as a co-infection with HBV or as a superinfection in a HBsAg positive patient. Diagnosis confirmed by finding serum IgG anti-delta. Superinfection results in an acute flare-up of previously infected chronic HBV infection. A rise in the serum AST or ALT may indicate is an indication of an infection. So then you have fulminant hepatitis can follow both types of infection, but is more common after co-infection. So hepatitis E is an RNA virus which causes hepatitis clinically similar to that of hepatitis A. It is an enterally transmitted, usually by contaminated water. It has a mortality from fulminant hepatic failure of 1 to 2%, which rises to 20% in case of pregnant women. The incubation period is 3 to 8 weeks. So after a short prodromal phase symptoms lasting from days to weeks follow, they include jaundice, fatigue and nausea. There is no carrier state and it does not progress to chronic liver disease. So an ELISA or IgG and IgM anti-HV is available for diagnosis. HEV RNA can be detected in serum or stored by RT-PCR, that is RT-PCR. Prevention and control depend upon the good sanitation and hygiene. Hepatitis G virus is also known as HPG virus or GB virus. So it is a virus in the Flaviviridae family and a member of Peggy virus genus. So blood-borne virus resembling HCV infection. So this has been found in patients with acute, chronic and fulminant hepatitis, hemophiliacs, patients with multiple transfusions and hemodialysis, intravenous drug addicts and blood donors. So this is just to revise all the types of viruses, like what is the structure of the virus, which I already explained, the route of transmission, what is the age being affected, whether there's presence of carrier state or not, then incubation period of each viruses, and then chronic infection, that is whether it progresses to chronic hepatitis, and what is the specific prophylaxis being given. Coming to the autoimmune hepatitis, this condition occurs most frequently in women. So it is classified as type 1 and type 2 and type 3. So in type 1, there is an association with other autoimmune diseases like pernicious anemia, thyroiditis, and Coombs positive hemolytic anemias. So pathogenesis is, the cause is unknown. It is proposed that in a genetically predisposed person, an environmental agent causes an acute autoimmune process to develop against liver antigens, producing progressive necro-inflammatory process resulting in fibrosis and cirrhosis. So in vitro observations have shown that there is a defect of suppressor regulated T cells, which may be primary or secondary. So the clinical features here, this rises in 2 peaks. They present in 2 peaks. That is in the peri and postmenopausal group patients may be asymptomatic or present with fatigue and elevated enzymes. So in the teens and early 20s, the disease that is type 2, it's called as presents with an acute hepatitis with jaundice and very high level of aminotransferases being elevated. So it says, which describes that the patient cannot, like it depends upon how the patient is going to improve with the treatment aspect. So this age group often has clinical features of cirrhosis with hepatosplenomegaly, cutaneous striae, acne, hirsutism, bruises, and ascites. What are the investigations? There is liver enzymes being raised. Serum gamma globulins are very high, frequently twice normal, particularly the IgG. In hematology, this progressive anemia, thrombocytopenia, and leukopenia. The prothrombin time is often very high, and they can later present with portal hypertension and splenomegaly. So coming to the autoantibodies which can be detected, there are three types of autoimmune that is autoantibodies. Type 1 is anti-nuclear antibodies and anti-smooth muscle antibodies. Type 2 with antibodies are anti-liver or kidney microsomal antibodies. It is most frequently seen in children and young women. So type 3 is with soluble liver antigen. This group behaves as type A. Treatment is by giving prednisolone 30 milligrams, which is given daily for 2 weeks, followed by slow reduction, and then a maintenance dose of 10 to 15 milligrams daily. Azathioprine should be added, that is 1 to 2 milligrams per kg daily, as a steroid sparing agent, and in some patients as maintenance therapy. So, what is the course and prognosis of this disease? Steroid and azathioprine therapy induce remission in over 80% of the cases, and the length of the treatment is lifelong in most of the cases. So liver transplantation is performed if the treatment fails, although disease may recur. So after knowing the individual types of viruses, the behavior of the viruses, the structure, and the pathogenesis, we have to classify as acute hepatitis and chronic viral hepatitis. So the viruses which causes acute infections are A, E, that is more than 90% of the viral cause, and hepatitis B and C viruses. Acute viral hepatitis is more likely to be asymptomatic in younger people. So symptomatic individuals may present after a convalescent stage of 7 to 10 days with a total illness lasting for about 2 to 6 weeks. So initial features are of non-specific flu-like symptoms. That is, most specific symptoms are profound loss of weight, jaundice, and abdominal discomfort. So these are the changes. That is the morphological changes which you can notice. There is a ballooning. This is a portal triad here. Completely, this is the bile duct reaction. There is there's proliferation of the fiber proliferation, or you have the inflammatory cells surrounding that. You have the inflammatory infiltrate composed of neutrophils and lymphocytes. So then ballooning degeneration of the cells could be seen. Apoptosis, that is a councilment bodies, could be there. And the necrosis could be related to, that is in zone 3, that's Pochi, bridging, and panacina necrosis. Sometimes you can see even fatty change in case of hepatitis C infections. And then cholestasis and interface hepatitis. Interface hepatitis means the proliferation of the bile ducts surrounded by the inflammatory cells. So these are the changes, morphological changes in cases which you see in acute infections. So chronic, the commonest viruses which cause chronic stages, hepatitis B without hepatitis D or hepatitis C infection. So these two viruses. Symptoms will be related to asymptomatic or complain of non-specific symptoms, particularly the fatigue. So specific symptoms include right hypochondrial pain due to liver distension, abdominal distension due to ascites, ankle swelling due to fluid retention, hematemesis and melena from GI hemorrhage, pruritus due to cholestasis, gynecomastia, loss of libido and amenorrhea due to endocrine dysfunction, confusion and drowsiness due to neuropsychiatric complications. Coming to the morphological aspects here, this again we related the portal tract. So you have stellate shaped portal triad with extension of fibrous spurs, that is into the lobules. The portal tract is expanded due to increased lymphoid aggregates. These are the lymphoid aggregates surrounding the portal triad. So which are seen in the breach, which breach the limiting plate. That is, the hepatocytes are the interface of the portal tract. And lobules are destroyed. So you can see the types of necrosis you see here is bridging, bridging necrosis or periportal necrosis, The fibrosis is bridging fibrosis and periportal fibrosis being observed. You have some of the hepatocytes showing ground glass appearance, and whenever there is fatty change, you can suspect the hepatitis C infection. So you have the consolidant bodies or the apoprotic bodies as well as the lymphoid aggregates. So these are the major morphological changes which you see in the chronic stage of hepatitis. Probably next class, after revising all the infections, probably next class I'll be talking about cirrhosis and portal hypertension and hepatic failure. If you have any doubts, you can mail me or you can ask me in the next class. Thank you for patient hearing.